Okay, I think we'll start. There is quite a number of people online. So welcome to the fourth BSET webinar. This is obviously the fourth in a series, and this is the final one. It's a great pleasure to welcome all of you who've joined online and also our faculty. I'm joined with my co-moderator, Paul Moxey, who's a consultant surgeon from St George's Hospital in London. And for those of you who don't know who I am, my name's Rachel Bell. I'm a consultant surgeon from Newcastle upon Tyne, and I'm the current president of BSET. One small notice, we're running a half-day BSET meeting next Thursday, to which you're all welcome to register. We would normally run a 2-day meeting where much beer and wine is drunk and lots of socialising, but because of COVID, we're unable to do that. So we're going to use the afternoon of next Thursday to run a mini BSET meeting, and obviously you're all welcome. So without further ado, I'm going to hand over to Paul to introduce our wonderful faculty.
Okay, good afternoon, everybody, or good morning or good evening, wherever you are around the world. Thanks for joining us this afternoon for the final session. We've got some very good speakers from all over, and we're starting with Professor Todd Rasmussen from the Mayo Clinic in the United States. And then we move on to Peter Subramanian from Adelaide, then Becky Sanford from St Thomas's in London, and we finish with Dr. Mike Park from Abu Dhabi. There's going to be a number of poll questions as we go along, and we're going to start before we hear Todd's talk. We're going to start with a poll, which hopefully you guys will be able to see on your screen shortly. I'll read it out for you. So, which statement is true regarding the optimal approach to the rescue of iatrogenic vascular injuries? So you've got a number of choices. You can choose A, all iatrogenic vascular injuries should be managed using less invasive endovascular techniques to ensure a quicker recovery. Or is it option B, that all iatrogenic vascular injuries should be managed using open surgical approaches to ensure adequate repair and durability? Is it C, that iatrogenic vascular injuries are amenable to non-operative management and most never require a procedure, open or endovascular? Or is it D, that iatrogenic vascular injuries should be managed using open and or endovascular techniques depending on their anatomic location and their clinical presentation? So we'll give you a minute or two just to vote. 70% of you so far have cast your vote. So there we go. The poll is closed.
Pretty unanimous, that.
That is unanimous. So yeah, I think that it's a good question, because it's already woken you up, hopefully, and got you thinking about the approach to this, and I suspect this leads very nicely into Todd's talk, and how you can't be too didactic about the way we approach these injuries. And so I think we'll come back and discuss this afterwards, but I think what we'll do is head straight into Todd's talk and hear what he has to say.
Well, thank you for the introduction, and thank you and Patrick and Rachel and the organizers of BSET 2021 for the opportunity to join you. I'll say good morning. I'm in Rochester, Minnesota, USA. So it's almost just a little past 8 in the morning. And I am pleased to be part of the panel. So I do have just a couple of disclosures about some consulting fees and editing royalties. None of these are really relevant to this morning's topic, but I did want to present them to the group in disclosure. I think the objectives this morning, for me anyway, I'm going to lead what's a really esteemed and experienced panel, and I'll try to get through my slides and sort of get out of the way. But I'd like to first provide some context and a framework on the topic of rescuing iatrogenic vascular injuries. So context as far as the scope of the problem, and then a bit of a working framework with which maybe we can learn and then approach these the very diverse group of scenarios moving forward. I'd like to just discuss and maybe touch on considerations regarding the anatomic location, the varied anatomic location of these types of scenarios, and then also the varied degrees of urgency. Some, as this group knows, are quite urgent or emergent, and then others can be pondered for a while and planned as far as the management. Also considerations regarding the source and the size of these iatrogenic vascular injuries can occur from a myriad of sources, which really then influences the management approach. Sort of also touch on and hopefully set up the cases that you'll hear in the subsequent from our subsequent panelists on the operative approach, the varied operative approach, whether that's open, endovascular, or hybrid. And then I think I have one slide. I just was going to kind of convey a system-wide approach that we've implemented at Mayo to try to maybe reduce the likelihood of these emergencies and then hasten our response if they do occur. Sort of a way that we've approached it to try to either prepare for or reduce the frequency of these types of emergencies. So we've already had a nice introduction of our panelists here. As I said, part of my job will be to be concise so that you can hear from each of these expert panelists this morning. This is this slide. I think it was I was trying to get my arms around the topic and the scope of this, and this is a couple of screenshots just from PubMed or maybe Google Scholar. I guess it's PubMed, just with the term iatrogenic vascular injury, and you can see I thought it was an interesting time a view of the sort of the time sequence or chronology of the reports on this topic and how they've really accelerated over the last 10 to 15 years. And then I thought the diversity of just the first even 10 or 15 articles, lumbar discectomy, discectomy, craniocervical region, femoral pseudoaneurysms, one can see endovascular procedures. There's sort of a myriad of causes to my point about the diversity of these vascular emergencies. And I think for vascular surgeons or those surgeons who respond to these emergencies, you kind of have to be ready for any of these on any given day. I did find some reassurance, I guess, in this as I looked at some of these reports to help us prepare. I think it's and looking at some of these, they were familiar cases. I suspect these topics will be presented, at least by some of our panelists' cases. And I think you can sort of become familiar with and then prepare for them using the literature like this. I have a couple of articles that were very recent. This article in the JVS that was just published, I think, in hard copy or hard print this year, talks about it's a broader article on the value of the vascular surgeon to the healthcare system. Many of you may be familiar with this. If not, I would refer you to the citation to dig into this a little bit. The focus of this article was not exclusively iatrogenic vascular injuries, but the article did emphasize and it quantified sort of the multidisciplinary reach of vascular surgery, including operative consultation, either proactive consultation from maybe a cancer physician, an orthopedist, or a neurosurgeon who needs spine exposure. So it really talked about proactive operative consultation or response, reactive or emergent, with these other specialties. And I think iatrogenic vascular injury certainly is touched upon in this broader article, but I wanted to sort of present this. And here, this is one of the figures from the article that shows the services requiring vascular assistance from a review in JVS in 2019. And these specialties will whether it's for spine exposure, hepatobiliary surgery, urology. These specialties will be familiar to the group. And again, I imagine some of the cases that will be presented subsequently will align with some of this article. This is just one topic area. I won't go through all of these, but it was a recent article in JVS about vascular repairs and gynecologic operations. I had not seen this article. I'd sort of missed it, but I appreciated reviewing this in preparation for this morning. And there are a couple of takeaways for me. One, that in regards to gynecologic operations, vascular repair, it's very uncommon. And this was a review of the NISQIP database. So, less than 1% of 200,000 GYN operations. However, as this group can relate, when it does happen, there's almost a tenfold increase in morbidity and mortality. 2% of these injuries, I thought was interesting. There weren't very many, but 2% were treated with endo. Ravi Rajani gave a nice invited commentary to that article. For those of you who know Ravi, you won't be surprised at his professional sort of summary in his commentary, where he says, despite these factors, the challenging factors associated with these scenarios, assisting other physicians remains one of the most fulfilling parts of being a vascular surgeon. Ravi's a consummate professional and excellent surgeon, and I appreciated his commentary to this article, which was on point and measured. So the approach to rescuing iatrogenic vascular injury depends. We try to tell our trainees they can't say it depends. They need to commit. It needs to be cut and dried or black and white. That is just not the case with iatrogenic vascular injuries. It really does depend. It depends upon the anatomic location, whether the injury is in the torso, the extremity, cervical region, junctional areas, either the thoracic outlet or the iliofemoral regions. And for those of you who have managed these injuries, that they occur in all of those. There's really not a portion of the body that's spared from this sort of a complication. So it does depend. Our response depends upon where it occurs. It depends upon the source of injury. These can be sort of simple inadvertent line placement, small caliber line placement, to major intraoperative injuries from a myriad of our surgical colleagues, whether it's orthopedic, head, neck, GYN, and certainly our own. We're culpable here as well. So it depends upon the size and the source of the injury. And then, of course, our response or our approach depends upon the patient's status. And patients can be hemodynamically normal and perfused. So maybe it's an extremity injury and the extremity is ischemic, but it's perfused and viable. Or the patient just can be in flat out shock, and or the extremity that's affected can be fully ischemic. And so our approach depends upon the patient's status. It also depends upon the surgeon or provider. Doesn't always have to be surgeon. We have many very talented interventional colleagues who also sort of save or rescue these scenarios, but it depends upon the tools and the capabilities, your imaging and endovascular capabilities. Here at Mayo, this is one of our 3 or 4 hybrid rooms. Almost always one of these is available, either to roll in an open operation or to do an endovascular type of repair. And of course, this is just one of the inventory rooms here. So if you're at a location like this, then your approach to rescue, maybe aired or skewed towards an endo or hybrid approach. In contrast, and I've had the privilege of sort of being in a situation like this. This is a tent hospital, very resource limited in Iraq in 2005. And if you find yourself in a really austere resource limited situation where, this is the operative board and this is your C-arm, this is a photo of John Eliason doing a rudimentary endo case in a real resource limited environment, this may skew you to more of an open approach to vascular emergencies because you don't have the imaging and endovascular capability that you do at a resourced location. So just, again, it depends. And I think you'll see this play out in the cases that are presented subsequent to my slides here. The open approach, it relies on standard exposures, proximal and distal control, those tenants. The repair can be either primary patch or just reconstruction of a vessel with interposition grafting. And these, of course, these are sort of some of the, whether it's a groin incision or a clavicular incision, retroperitoneal to control, for example, inflow to the femoral, SFA exposure above or below the knee, and cervical exposures or upper extremity. These are just traditional sort of the open approach and the tenets of proximal and distal control. Endo, as the group knows, I mean, this is the society knows this well. It does allow remote or less invasive balloon occlusion for proximal control, deployment of a stent graft to seal the injury, or coils or plugs sort of to treat the source. So there are definitely some nifty endo approaches that can be deployed to get you and the patient out of a jam from an iatrogenic injury. I tried to put together just a framework. I did this last night, so you'll have to forgive me and feel free to correct. But I know it's a forgiving audience. You know, I tried to sort of think through, and maybe this framework will play out in some of the cases. I guess if I'm called, or one of our trainees is called, you know, with one of these injuries, is the patient hemodynamically unstable? So if they're unstable, meaning in some degree of shock, then I sort of have to say, is it in the extremity? Is this something that's, they're bleeding from the extremity? Yes or no? If they are, typically extremity vascular injuries just can go to open repair. If this is a bleeding brachial artery or a bleeding or even ischemic popliteal artery that's sort of urgent, then it can be, it's more amenable. This isn't uniform, but it's more amenable to an open repair. If it's not in the extremity, it's in the torso or the thoracic outlet, sort of junctional region. The question is it endo amenable? And so this depends also where you are, but if it's endo amenable, or if it's not endo amenable, then you're just probably going to have to do an open repair. If it is endo amenable, you sort of say, well, do I have the capability? Do I have the imaging available? Do I have the inventory available to do it? And if it's in the torso or junctional region, it is endo amenable, and you've got the capability, both imaging and inventory, then a hybrid repair. If it's not, then you're going to have to proceed with an open repair. If the patient's stable, then I think you have more time for planning, maybe a CTA. You know, if they're unstable, oftentimes you don't have time for preoperative imaging. But if they are stable and it's endo amenable, then or it's not endo amenable, you can sort of plan for an open repair. If it is endo amenable and you have the capability, then a planned endo or hybrid repair. And if not, you'll have to sort of go to a planned open repair. Again, I think the confusing nature of this slide speaks to the variety of these injuries. You can't really make it didactic, as Paul said in his opening remarks, but I can't help myself to try to give some structure framework for us and our trainees. So the last thing I'll close with, and then we'll move to our cases. You know, I will say that at Mayo there is sort of a system-wide approach, and this may not apply to other places, but you know, how can we maybe employ a system-wide approach that reduces the incidence of these types of scenarios and improves our response if they do happen? So at Mayo, among our 6 or 7 vascular surgeons, we have one of them dedicated on call all the time off of elective clinic and elective operations, basically as a day call surgeon, and then we have a night call surgeon to support planned secondary cases. This and emergencies, of course. But having a day call surgeon has been interesting because it allows proactive planning. The institution knows, our orthopedic surgeons, our GYN surgeons, cancer surgeons, they know that our service can commit a vascular surgeon to support them in their pancreatic resection or their sarcoma resection, and they don't I think that enables and fosters proactive communication with these tough cases, GYNs that going back in a third time and they're going to use a scope. We'll get called and we'll sort of be there, or our fellow can sort of be on alert. It's not perfect, and I'm sure the system doesn't apply to all other places, but I have found it interesting to set aside a vascular surgeon to sort of proactively communicate and support secondary cases, and then respond to emergencies if they do occur. So I think just in my sort of brief remarks or conclusion, these vascular emergencies, they're uncommon, but they certainly are high stakes. They're high stakes scenarios for patients, providers, and the overall health system. And I do think, to my last slide, it is imperative that we try to find ways to sort of reduce the frequency and improve our response. I think that rescue depends upon factors that I mentioned. I think you'll see the diversity of these presentations and our response to them and our panelists and their cases. And then, as I mentioned, a system-wide approach that allows us to be ready to support proactively or respond to reactively, I guess, these secondary cases could improve practice metrics, including outcomes and then satisfaction. So I'm going to end my comments there. And I don't know if I'll turn this back to Becky or to Paul. And thank you for the opportunity. And I look forward to some discussion and the next presentations.
Thank you very much, Todd, for that fantastic opening presentation. It's a really good framework for basing how you would think about managing an iatrogenic vascular emergency that just comes out of the blue. I mean, I totally agree with you that flexibility is the most important thing. You have to think outside of the box quite a lot. And I've been involved in quite a lot of colourful sort of variety of injuries, none of which I was expecting, often in the middle of the night. I think it's also important to have a few friends that you phone for help or advice for the weird and wonderful things that you may have never come across before. But a really great start to our webinar today.
Great, thank you.
Thank you very much. I'd like to encourage any of the participants to write any questions they would like in the Q&A bit, and we will try and answer them as we go through. So just type your answers in, and Paul and I will moderate them and try and get them answered by the faculty.
Because Rachel, I know, sorry to interrupt you, I noticed people are raising their hands, and I wonder actually whether it's better for people to type a question into the Q&A box rather than raising a hand. I'm not sure we can go to people directly.
Yeah, so please type in the Q&A box, and then we'll be able to see that you've got something to ask if you ask a question, and we can filter them through. So questions for me, for Todd, and any of the other faculty can contribute because there aren't any questions coming through on my Q&A box at the moment. So I really like your system of having a surgeon on call all the time at the Mayo for these sorts of things. Have you got any data to show that it's improved outcomes for those, regular offenders, the cardiologists? I'll just put it out there.
Yeah, that's a great question. And I don't know that we have data yet, although we're reviewing it. And I think the biggest thing is the day call, right? There's always a vascular surgeon on at night, but I think setting, our group has a day call surgeon schedule out now through the end of the calendar year, so that our cardiologists, our orthopedic surgeons, spine surgeons, they know if they're tackling a tough case, they can go to the vascular day call and they can sort of communicate with us, and we don't schedule. So when you're on day call, you just don't have any other clinic or scheduled operations. So you are able to, again, I think part of it is proactive. It's not perfect. That doesn't prevent all of these, but it's been an interesting, I think, change in the practice here. And I think we don't have data, but I just think sort of the perception is that it improves proactive planning and communication, and then it may improve metrics. The other thing it has done is greatly expand the practice's secondary case volume. I think to the point of that JVS article about the value to the health system of the vascular surgeon, the number of spine exposures has increased, the number of reconstructions associated with tumor resections has increased, and so we do have that data. It's expanded the overall sort of practice, I would say.
Yeah, no, I think we've seen the same thing. We get called so much. I like to be called in advance to know that they might need a vascular surgeon, because you get a bit of warning and you know what you're going in for.
Right. And I think conversely, I think that all of us can relate to being on call when you have a scheduled clinic. So when you're the call person and you're in the middle of your clinic, that is the antithesis of sort of what I described, or you may have your own elective aneurysm on and you happen to be on call. You just can't respond as effectively, nor can they plan cases with you as effectively. So
no, I think the most stressful thing for me still, 15 years into being a consultant, is trying to be in two places at once.
Yeah, exactly.
I think it just doesn't work. So I commend your system. I think it's great. There are some questions coming in now on the Q&A rapidly now. You said there weren't any. So somebody's asking about iatrogenic area and areas we don't normally get trained in exposure or access. How do you get training to be prepared to do that sort of difficult iatrogenic injury in those areas that we don't often access electively?
Yeah, that's a good question. How do you get training? I think that, that's a difficult one. I think that's going to be, I think that if you find an injury in an area where you're not experienced at accessing, then, with imaging and potentially with endo, it depends upon your endo expertise, you can perhaps better define it with imaging and control it with an endo. Let's say it's high in the neck, zone 3 neck injury or something, carotid, and then phone a friend. I think at some point you if you don't have the experience in exposing it, then you'll have to find and sort of assemble that capability as best you can. I don't know what others in the panel think of that.
So there are a lot of the motions involved with a emergent, let's say, retroperitoneal exposure. The transplant exposure, for example, that's we kind of grew up doing it, sort of doing this and taking all the peritoneal sac away from the pelvis. That motion still exists in spine exposures, in urologic surgery, and in a lot of general surgery. And so there may be opportunities to scrub into those cases and get your hands into that space. You only have to do it a couple of times, and a good spine exposure will teach you how to expose the whole dang aorta from the diaphragm down to the pubis.
Yeah, good point.
Yeah, and I agree with that. And actually, this sort of day call system you've got, where you get involved with joint cases like sarcoma excisions and things like that, where you go into places you're not in a different way to get tumors out. You get to know the anatomy in different areas, and you get to learn things. So actually it's quite educational. I find it's quite educational doing joint cases with other surgical specialties. You learn things and you see different exposures, and it does help you when you get yourself into sticky situations elsewhere.
Rachel, there was a question, I think it was Max, about the day call issue, and how to convince administration that in fact that's a good thing.
Yeah.
So at the Royal Adelaide, we have a unit of about 7 or 8 vascular surgeons, and we have a concept called the Consultant of the Week to completely address what Todd's talking about. That person is available during the day to deal with ward emergencies, the odd iatrogenic injuries and so on. And Max's question was, how do you convince administration that actually works? It works if you can demonstrate that having a day call surgeon in your system reduces the number of, unpredictable or after hours, calls that are made, because that's a big resource in our system here in Adelaide. It's a costly resource. The problem with that, of course, is you need enough operating time and angio suite space, etc., to be able to deal with the day call work, so that you don't end up, seeing all these things that need to be done, but you don't have the, capability of doing it. The other issue regarding, the joint cases, the large tumors, etc., it's the sort of stuff that you need to actually be involved in the planning of. Someone wants to take, resect a tumor that's stuck to the IVC. You don't want to know about that, on the day that it's happening. You want to know about that, a week or so before. You want to be called to the MDT and so on. And the way we deal with it is we've got a couple of surgeons who are quite engaged in doing that, and we provide them with that volume of work and the time and capacity to do that. But I think your last slide on the system to deal with the unpredicted vascular work is a key slide, and I think it's important across all our different jurisdictions how we deal with that.
The paper from John White about the value of vascular surgery speaks to, hints at this. What a day call system is basically is a vascular hospitalist, a vascular intensive surgeonist, call it what you will. And if a healthcare system is committed to that next level of quality, they have to think in these innovative ways to muster the resources properly. But again, it hits up against the reality of revenues and how you're going to make it pay for itself.
I totally agree. I think it's always definitely that sort of system gives a better quality of care, both for your colleagues in other surgical specialties, but also for the patients involved. But it's quite difficult to show that it's financially beneficial. It definitely gives better quality, but not necessarily value for money. But I would argue that having a vascular surgeon there for a planned case, you're less likely to get a complication. You could probably save yourself thousands and thousands of pounds, avoiding vascular complications because somebody's present in an operating theatre giving expert advice. But that's really difficult to show on a bottom line, unfortunately. So it's a patient safety and quality issue. Excellent.
I was just going to say there, Rachel, along those same lines, was that because your colleagues tend to hugely value our input, if business cases are being written, etc., then you can carry those colleagues along with you, because they'll often very much want to support us being on site. One other quick point I wanted to make about how do you get this training. Certainly in the UK, we don't have a huge amount of trauma, certainly not. And I suspect Todd, for example, has been a military surgeon and will feel a lot more comfortable in these situations than, for example, someone who's only just qualified in the UK as a consultant, because we just don't have that exposure. And there are some very good courses, particularly cadaveric courses. The Royal College of Surgeons in the UK runs the Definitive Trauma Skills course, and particularly for those junctional injuries where it certainly helped me when I did the Definitive Skills course and then had a trauma in the upper limb junctional region, and it was hugely helpful to have be able to do that on a cadaver, less than a year before I was appointed. So anyway, I think they were my 2 points.
Great point, Paul. Thank you. So thank you very much. I think we'll close this little part and move on to some of the case presentations. Before I do that, I have to go to our second poll question, which hopefully Jeanette will have. Well done. Brilliant. So this is our second question. So which of the following statements best characterizes the immediate assessment of iatrogenic vascular injury in the abdomen and pelvis? And there are four responses. So the first is easily detectable by physical exam and immediately reflected in the patient's hemodynamic status. Second is difficult to detect with physical exam and may not be immediately apparent in the patient's hemodynamic status. Suspicion for injury in the abdominal pelvis requires immediate exploratory laparotomy is the third. And the immediate assessment of iatrogenic a vascular injury in the abdomen and pelvis requires an immediate CT. So off you go, vote appropriately, or as you think appropriately. This is slightly less unanimous than the previous poll. So you've got a little bit more time. Oh, the poll's closed now. Excellent. So the majority think it's difficult to detect with physical exam and may not be immediately apparent in the patient's hemodynamic status. I think I would agree with that statement, but there's a smattering of others, and lots of people said immediate CT scan. I'm looking at Todd as he came up with the questions. But yeah.
Well, I think that, I guess, yeah, I think, again, it depends. I think if the patient, if there's an urgency to, if there's a suspicion and then an urgency to identify it, then I do think expeditious CT scan, and the patient can get to the CT scanner, then CT imaging is very helpful.
Okay.
I think there are some scenarios where if the patient's hemodynamically normal and otherwise stable, that you can watch and follow patient's physical exam and laboratory assessment. But it is difficult. I guess the point is it's difficult to determine. You know, it is difficult in the belly and the pelvis sometimes to know if there's an injury, or if there is, if they're bleeding, how significant.
Definitely. Thank you very much for that. So without further ado, we're going to move on to Peter Subramanian and his case presentations. Peter's very kindly joined us from Adelaide, not the moon, as his background would suggest. Thank you very much, Peter.
So thank you, and thank you, Patrick and team, for inviting me. I'm very pleased to be part of this and to actually learn as I go. So the webinar has been structured to enable participants to develop a systematic and effective approach, and I think you've already seen the key principles that Todd has outlined. So my role, as together with my other panelists, is to present you some cases to demonstrate some of the key learnings in the management of iatrogenic vascular injuries. I think while this might occur in non-vascular procedures, we also should have the humility to understand that iatrogenic vascular injuries can occur in vascular procedures too. So to my first case, this is a 74-year-old male that had a subacute presentation to the emergency department of a private hospital here in Adelaide with sudden onset of back pain. He'd been well previously. He had a past history of an open aneurysm repair about 11 years ago. And this case was actually a few years ago, so 15 years ago, I guess. And it was an uncomplicated open repair with a bifurcated graft. And the patient was previously well. So acute presentation, had a contrast CT, which demonstrated a contained false aneurysm at the proximal anastomosis, with a limited amount of retroperitoneal hematoma, but certainly a large aneurysm. And that's just a representative image that I've got there for you. So we talked very quickly about this because this was a potentially unstable condition, and our plan was to manage this by open repair with supraciliac clamping and possibly an interposition grafting, because we didn't think this was an infected aortic graft. And the length and the diameter of the main body of the original aortic graft did not lend us to an easy endovascular solution. So we prepped the patient and consented the patient, and we took them to theater. And during the preoperative preparation for surgery, due to the high probability of requiring a large volume rapid transfusion, a multi-access central catheter, which you may or may not be familiar with, was decided by the anesthetist to be used as the method for providing central access. And this large 9 French catheter was with 3 lumens. It's introduced by a sheath, and it's for rapid fluid resuscitation inotrope administration and to facilitate additional monitoring with a Swan GANS. So on here is a picture of this catheter. Concern, of course, on deployment of the catheter, that there was potentially an inadvertent arterial injury. And I commend my anesthetic colleague for realizing that this was a possibility. He got an arterial back flush. The patient was stable. We got some contrast down the MAC, and as you can see, there's some extravasation on fluoroscopy. We confirmed that the patient was hemodynamically stable with no clinical evidence of an expanding neck hematoma. We got some rapid peripheral access. We ensured that all the relevant teams were notified, including our cardiothoracic colleagues. And we shifted the patient down to the angio suite because at that stage, our angio suite was separate from our operating theater. So these were the teams that we communicated with. So cardiothoracic team, interventional team, management plan discussed and confirmed. We got a rapid wire access, both from the right brachial. We used a 6 French and an 8 French from the groin. Now, the initial assessment of what size sheets we were going to select was premised on the basis that we had made a decision that we were going to treat this with a covered stent. And we wanted the ability to rapidly deploy this with either a stent or an occlusive balloon should the patient become unstable. So a 10 by 58 millimeter live stream balloon expanded stent was positioned across the site of the arterial puncture. And we had a second stent prepped and ready for when we simultaneously deployed the stent and removed the MAC sheath. And as you can see here, there was still extravasation. The patient was still stable. We deployed the second stent and we achieved seal. No extravasation. Vertebral was patent. Internal mammary was patent. Wrist pulses were patent. So that was a good completion angiogram. And here's the critical part. We had to make a decision as to what we were going to do next. And I think that's an element in the management of iatrogenic injuries that we have to really consider. Now, in this patient with a contained rupture, with potentially unstable, we had made the decision that we would proceed, and we proceeded with repair. At the end of the entire procedure, we had a post-event brief with the proceduralist and the team, and that is a key element in managing these iatrogenic injuries. The second case study, here was a situation where we had a 66-year-old female with metastatic cancer, pancreatic cancer, undergoing chemotherapy, and you can see that there's a portacat in one of the subsequent images. She presented acutely with a small bowel obstruction, with pneumatosis on plain X-ray and clinical suspicion of ischemic perforation. So we discussed the situation with the patient, or at least the general surgeon did, the patient's family and the treating teams, and a decision was made to proceed with palliative laparotomy. A supraclavicular approach to central venous cannulation was undertaken using standard Seldinger guide wire technique to establish CV access using a 7 French triple lumen CVC. An inadvertent arterial cannulation was recognized on insertion, again with once the CVC was in, and there was the concern was that the inadvertent cannulation was recognized and discussed. So what were we going to do? We had a CVC and the patient was stable. We notified everyone. That was when I was notified. Vascular surgery, radiology, ICU. Team huddle and discussion. The decision was taken to proceed with laparotomy because the patient was stable. We did not think there was any active bleeding from the site of puncture, and the palliative laparotomy with the details of which are noted on this slide continued. The patient was transferred to the ICU, remained tubed and stable. But we had a very close look at the plain X-ray. And if you have a look at this, there's information that's available on this X-ray. The CVC is looped. That raised our concern that this was in fact not just a straightforward inadvertent subclavian arterial puncture, but this may in fact represent a junctional injury, a junctional cannulation of the subclavian artery, and that was suspected. We took the patient to the hybrid suite. In this instance, we had access to a hybrid suite, and diagnostic cannulation did confirm our concerns were confirmed. So this is when you call your friends. So I called my friendly interventional neuroradiologist because I had concerns that the vertebral artery had actually been cannulated. And that was going to be a more complex fix. So right brachial access was achieved. And you can see here that we did selective runs of the right vertebral, confirmed that it was patent. And we made a decision at that stage after consultation with the imaging review of the patient that the methodology to treat this would be with a vascular closure device. So an 0.14 cannulation of the right vertebral occurred. A 0.35 glide wire cannulated the CVC. Partial systemic heparinization due to the fact that we were instrumenting the vertebral artery, and a 3 millimeter balloon was placed in the right vertebral, not inflated, and a decision was made to use an angioseal bioabsorbable anchor and collagen plug to deploy and to achieve a seal. So that occurred, and completion angiography demonstrated that no extravasation, flow in the right vertebral, and the patient remained neurologically intact. And of course, the debriefing again with patient, family, and the team. The Australasian Vascular Audit records 27 cases of iatrogenic subclavian arterial cannulation over a 10-year period, with the majority involving the right subclavian. This is not a complication without some significant risk. 3 deaths were reported in this series, giving you a mortality rate of 11%. The treatment options recorded in this group of patients from the AVA included open surgical repair, manual compression, the use of a covered stent, and in 33% or 9 of the 27 cases, off-label use of percutaneous vascular closure device. Again, I think Todd has made mention of the importance of appreciating the location and the local anatomy where these vascular injuries occur, whether they were in the carotid, the innominate or brachiocephalic, subclavian or vertebral arteries, all bear a relevance in terms of decision making, and it's reflected probably in the range of different techniques used. In all but one of the cases of open repair, catheter angiography was performed, and there was a single case of coil embolization of the left subclavian artery performed. Of the cases that used vascular closure devices, again off-label, these included the ProGlide, suture close, plug-based, the AngioSeal, and the titanium clip, the star close. And while these have demonstrated significant benefits in terms of routine endovascular work, its use in the treatment of inadvertent subclavian injury remains off-label. And while successful deployment is great, the consequences of failure can be catastrophic and must be recognized. So what have we learned from these 2 cases? And I've tried to summarize it in the lessons that I've learned. If in doubt, please do not pull it out. Now, it's to resist the human instinct. There's a sense of panic. I think there was a do not panic in one of Todd's slides. And the other thing is to remember that you've got a patient, not just a potentially calamitous injury. Intelligently interpret the imaging. Even the non-contrast plane imaging that I showed you earlier had some valuable information. And of course, expedient angiography provides more detailed imaging, but equally important, it allowed us to deploy a wire access to give us the get out of jail card in the event that things went badly very quickly. Develop an understanding of your endovascular options, and I think you've seen and you saw the slide that Todd had. What can you do? What do you have on the shelf? Who do you have to help you? Think, plan, talk to everybody. Everyone's a part of the team. No turf wars in the middle of managing one of these. And prepare for all eventualities. You do need to let the cardiothoracic surgeon know that if you don't fix this in an endovascular technique, you're going to need them. And I think it's also important to debrief honestly and sensitively with your colleague and your team later. A final quick case, if I can be indulged, this is a 29-year-old female with a history of mental health issues. It's a car versus pedestrian. This was a case treated a few weeks ago by a very talented colleague of mine at the Royal Adelaide, who's actually a British export. We've decided we'll keep him. The extent of injuries are listed here. The particular injury is the compound comminuted displaced tibial fracture, which was initially stabilized with an external fixator. You see on the pan-CT that the extent of the tibial fracture is multiple fragments and displacement is noted. At this juncture of the case, all pulses are present. Patient is hemodynamically stable and has followed routine trauma protocol and is stable. 24 hours later, the patient is taken down for an IM nail of the comminuted tibial fracture with 2 proximal blocking screws that are deployed using a 10.5 mil drill bit with a tourniquet in. First sign of an issue is when the orthopedic registrar says, I think I can't find a bit of this drill bit. The lateral incision is extended, drill bit fragment is removed, bleeding is noted. Now I have to again congratulate the orthopedic registrar for recognizing that there was a problem. He took the tourniquet down, the foot was dusky, no pulses, and he called. Joe Dawson, who's the talented surgeon that we're not planning to send back to the UK, then performed the angiogram. You can see the occlusive injury to the TP trunk and AT occlusion. He explored via the standard medial approach, performed a fasciotomy once he worked out that the revascularization is going to take some time. There was a large hematoma and there was likely to be over 4 hours of ischemia time. So that was dealt with in the usual way. I won't go through the particular operative repair. It might come up in discussion later, but ordinarily we'd use the contralateral long saphenous, but that was not suitable. So an ipsilateral long saphenous vein was used and an interposition graft performed with the usual technique. Foot perfused, PTA pulse palpable. We know about the risks of vascular injuries with tibial nailing because it's in the literature. Generally, it tends to present quite late, false aneurysm, delayed presentation, but in this instance, there was a very acute presentation of iatrogenic injury. What did we learn from this case? Changed clinical status, even in a trauma patient, requires imaging. Again, we manage the patient, not just the iatrogenic injury. There was information in the x-rays and the imaging that provided us with an understanding, but we also benefited from understanding the detail of the problem. Talk to the surgeon who's been involved in the original case. They will have information that's of relevance. Devise the surgical plan and communicate it. The anesthetist, the ICU, the theater teams, they've got to know what you're planning to do. And again, be cognizant of the need to focus on the patient, not just the procedure. And remember that the original surgeon will be focused on the primary procedure. more so because of the inadvertent vascular injury. Be mindful that you don't get caught up in clouded decision-making because of that. Think, plan, talk, and work with everybody and prepare for all eventualities. Finally, debrief honestly and sensitively with your colleague and the team later. Your colleague will appreciate this as much as he or she will appreciate your heroic vascular rescue. So really thank you for giving me the opportunity to share these 3 cases. I hope they've been instructive. Thanks, Rachel and Paul.
Thank you, Peter. Actually, St George's doesn't look anything like the Royal Adelaide. That's a very impressive building. I had a couple of points I wanted to ask you about initially. The issue around closure devices. I assume that you're sort of pretty comfortable with them on a day-to-day basis anyway, and probably use them off license, closing 20 French holes anyway. In your standard practice, would that be fair if you're then going to use them in an acute situation like you described?
I think you need to know your closure device, and you need to know how the deployment sequence, and you also need to know what holes you're not going to be able to close. Even with our Pro Glide, there is a point of no return when you take the wire out, and you've got to be able to deal with it if you don't achieve closure. So yeah, I wouldn't advocate using a closure device in an iatrogenic injury if that's one of your early, in your early experience.
Yeah, that was sort of my what I wanted you to say. And I agree. I mean, with Pro Glides, we use a lot of them, and obviously we like them because you've got your wire access, and so if it doesn't work, you can put another one and maybe even another one in, and then if that doesn't work, you can put a sheath in and have a breather and then cut down and fix it. And I think that's off the top of my head, that's the only one you can do that with. But it is a bigger device, isn't it? It's a 7 French device. My other question was around why so many subclavian lines. Is that because of this multi-channel catheter that you described? Does that only go in we don't see very many in the UK. We used to do them when as a house officer, we used to put subclavian lines in but we don't do very many anymore. Most of ours are jugular lines.
Yeah, so Paul, I'm not sure that these were intended to be subclavian lines. Okay, I think this is inadvertent, injury. And to be honest, I haven't been able to, and I think there was a slide that Todd showed, the incidence of using closure devices and so on is more recent. But I think the use of ultrasound guided punctures has probably reduced the number of inadvertent approaches. It's useful to talk to your intensivist. The MAC catheter, for example, I had to, work out what's this big thing. It's a 9 French sheet thing, and it's designed really for the rapid infusion that is thought to occur, because you're doing a redo aortic procedure. So I guess one of the things that I probably didn't get across is try to understand the mechanism of the iatrogenic injury. There's a story that understanding the device has, and if you know what device it is, you make that decision. And I think Todd mentioned it a bit. You make a decision regarding whether an endo approach is going to work, or this is going to be a dirty big hole in the subclavian artery that's not going to close. Which is the reason why we used the covered stent for the first case I presented.
Yeah, I agree. That it's worth going to find out about the different lines people use, and that changes all the time. We got called recently to one of these cooling lines that are put in for cooling, which we'd never come across, and it's just essentially, as you say, dirty great big pipe. But we weren't familiar with it when we were called to the havoc that it had caused, and so it's worth probably. I think that's a very good point. Going to have a chat with the usual offenders and see what they're using at the moment. Maybe even wave an ultrasound probe at a cardiologist and suggests he uses it, or she. Shall we shall we move on to our third poll, unless there's any questions that have come up that we could answer? There's been a few questions about ultrasound guidance. I think we've largely answered that, which is that I think the evidence is overwhelming and it's almost indefensible, I would say, to not be using ultrasound to puncture a blood vessel.
Any cardiologists on the call, please take note.
Yeah,
I would agree with that, Paul, but our unit have mentioned about the training that they get, and particularly not so much the youngsters coming through, but people who've been doing this for a number of years very sort of safely and competently without ultrasound, and that they actually feel a little bit out of their depth being thrown an ultrasound probe without the backup of training and mentoring and how to use it and interpret what they're seeing. So I think they're often quite actually complex situations to sort out and to change practice, despite the fact that most of our practice has fully evolved to using ultrasound.
I think it's probably something that will die out, isn't it? In time, but I take that point completely. That if it's something you're used to and you're good at it and you can demonstrate you've got a low complication rate, then you should probably carry on doing it. But I think most trainees coming through now would be being taught how to do ultrasound guided punctures to begin with.
The thing is, I mean, I'm old and I trained without ultrasound guidance. I used to put everything in. I did ITU jobs, put loads of lines in without an ultrasound. But I am a complete convert and I have gone the other way. I don't think it's impossible to learn. I think you just need a will.
I totally agree, but I think we also perhaps can lead the way in terms of facilitating training. I know that you did a lot of work with the Ecmo team, Rachel, at Thomas's, to kind of build a skill set around the things that we know from vascular surgery, and we can actually support our colleagues in training and mentoring in that process, can't we?
Yeah, there's a comment coming up there about someone else commenting that it's difficult to get their more senior colleagues to use ultrasound. But Rachel, I completely agree. Actually, I mean, I was trying to be diplomatic, but I don't understand.
Well, I am old. Is that what you agree?
No, well, that as well. But I was trying to about. I don't see how you can't pick up an ultrasound probe and learn to use it quite quickly. But I'm being less diplomatic there. Okay, I think in the interest of time, let's go to our third poll question. So there you go. It's on your screen in front of you. So I shall read it out for you. So again, for possible answers, which of the following endovascular techniques has not been shown to be useful for stabilization and or repair of iatrogenic vascular injuries? So the placement of a balloon occlusion proximal to the site of the injury, placement of a covered stent across the site of an injury, use of an atherectomy catheter to remove plaque from around the vascular injury, or placement of coils to occlude a vascular perforation and pseudoaneurysm. Less than 50% of people have answered so far. Come on, be brave. We can't tell who it is that's answering. Let's have a guess. A few more answers coming in. Very good. Okay. We seem to have a fairly overwhelming consensus that the use of atherectomy catheters to remove plaque from around a vascular injury site is not correct, and that is what Todd has suggested. Although I should imagine, don't give it some time and there'll be someone that gives it a go. But yeah, that the others are all things that I think most of us can recognize as a technique for stabilizing or repairing vascular injuries. Atherectomy, not so much yet. Excellent. Okay, so we'll move on to our third speaker. Becky Sanford is going to present some cases for us from her practice at St Thomas's, and I shall hand you over to Bex now.
Thanks ever so much, Paul, and thanks everyone for asking me to be here today, and thank you for the fantastic talk so far. It's been a really fascinating meeting so far. So I thought what I would do is just share a couple of the cases that I've come across that highlight some slightly different aspects of decision-making and practice around iatrogenic injuries. And I thought I'd start by sharing the very first case that I was asked to be involved with as a consultant. So I'd been in post 3 months, and I was in the middle of a pretty hectic clinic that I usually did with a couple of colleagues over at Guy's Hospital. And on this particular day, I was there on my own with a fairly full waiting room when I got a phone call from a colleague at St Thomas's to say, Bex, are you at Guy's? I've got this mate who's in the urology theatre and he wonders if you could give him a hand because he thinks he might have just cut through the SMA. So 3 months into my consultant post, I took quite a deep breath at that phone call and then toddled along to the urology theatre. So this is a hospital that I wasn't overly familiar with at the time, but I could find my way there. And I found them doing a robot-assisted laparoscopic nephrectomy for a big renal tumour. The gentleman involved was the father of the medical student, just to make life even less stressful. And this was the scene that I saw when I got there. This in the background is the aorta, and this is the kidney up at the top. And this is what was divided, thinking this was the renal artery. This is the renal vein here. And then as they continued to dissect backwards, they found this thing here, which was another renal artery, except we didn't think this gentleman had 2 left renal arteries. So I had a look at the CT scan to see if I could understand what had happened. And if I just stop this here, this sort of point here. So what you can see is there's this huge tumour on the left-hand side. And then as we come down, you can see the left renal artery here, and it actually comes off above the SMA and the right renal artery. So abnormal anatomy and easy to see how a mistake could have happened in that context. So a very wise vascular mentor of mine once told me there are 3 questions you need for emergency vascular surgery. Do they need an operation? Do they need it now, or when do they need it? And where do I make the cut? And the rest of it you can probably work out as you go along. So what were my answers to those questions? Well, first of all, yeah, I think the SMA probably is transected, and yes, I think we need an operation. Do they need it now? Well, this patient had a lactate of 0.7, and we'd swung the laparoscope round and had a look at the bowel, and it was all pink and healthy and peristalsing. But on balance, it's an SMA transection, so yeah, we should probably get on and repair that now. So my third question, where do we make the cut? Well, this isn't massively familiar territory to me. I don't do it every day. But I've got 3 urologists by this stage rubbed around the table. So I said, well, can you make me a cut that'll get me right onto that bit? And they said, yeah, we can do that. So then I had one question from them, which was, where are you going? As I left theatre to get some mobile reception. And the answer was, of course, I was going to use a lifeline and phone a friend, because this was a high stakes injury, potentially a life-threatening injury, and needed a time-critical, perfect repair. I was in an environment which was unfamiliar to me, without any of my usual kit, and without an assistant who was skilled in vascular surgery and used to operating with me. And that was the only thing that I could alter about that situation. So I phoned a friend to come and help. And then I went back in and scrubbed. And whilst I was scrubbing, the urology team had opened the abdomen and removed the kidney, which was fantastic. And they had made a cut that got me onto exactly that bit. And so what I was looking at then was the end of the SMA, as we just saw on that video snapshot. But I could see the distal end of the SMA. So I went back to first principles and mobilized the distal SMA and refreshed the ends of it and had a little look to see if I could just do a primary end-to-end anastomosis or if this was going to need an interposition graft. And actually, it just came together very nicely with an end-to-end primary anastomosis. And by the time I got to the bit where I was having to do some stitching, my colleague had arrived from St Thomas's to give me a hand. And so actually what had sounded like a really threatening situation became really straightforward and easy repair with loads of space, plenty of access, and a skilled assistant. Unfortunately, the post-op CT scan doesn't look too terrible. The patient did okay, he never got mesenteric ischemia, and he did well. So what did I learn from this case? Well, I think it was worth taking a few minutes just to recognise the injury. I think it was worth looking for the unusual anatomy, and I suspect that that is more commonly associated with cases of iatrogenic injury. I think probably the injury happens for a reason, and sometimes it's because of funny anatomy. And I think there's definitely something to learn about using the skills of the whole team, rather than arriving with my cape on and feeling like I could save the day. Actually asking the urology team to do the bit that they're really good at enabled me to do the bit that I was good at without needing to feel like I had to tackle it all myself. And it also has the benefit of enabling the surgical team to be involved with every aspect of salvaging the situation, which I suspect has a good team building and psychological impact if you feel that you've caused an injury. So the next case was also at Guy's, and we talked a little bit about line access, and I totally agree, ultrasound is a great thing. We sometimes also get it wrong even with ultrasound, which was the case in this one. This was a 60-something-year-old gentleman who was coming in for a cadaveric renal transplant. And this line had been sighted in the night. So it was about midnight when the patient came in for his transplant. And actually had been discussed with my colleague on call overnight, rather than myself, I wasn't on. They decided between the transplant team and the vascular surgeon and the anaesthetist that they would stop the case, actually. And they woke the patient up and monitored them overnight, but didn't immediately remove the line. When they woke them up, there was no neurological deficit. There was no expanding hematoma, although there is some hematoma in the neck. And so we had time to have a think about what we wanted to do. And we kind of came up with 4 potential options. We could pull it out and press, but this was a 13.5 French trialysis catheter, so none of us thought that was a very good idea. We could use a PERC closure device, and I think there are lots of advantages to that, and we could have potentially done that. But actually, when we looked at the scan in detail, it looked like this puncture had gone through and through the internal jugular vein. And this was a transplant, or a patient on hemodialysis who'd been awaiting their transplant. And so we didn't really want to run the risk of causing a central venous stenosis, because that jugular vein might have been useful in future dialysis situations. And then we thought about the option of a covered stent. Again, an attractive option, favourable arch anatomy, not a lot of atherosclerotic disease, so a covered stent would have worked well. But again, if we come back to this patient was on HD, so repeated needle punctures and potential for bacteremias. And so we actually came down with the option of open surgery. This is a surgically accessible bit of the neck, something we're all pretty familiar with. You'll notice it's not the most friendly shape of neck, and there is a bit of hematoma around there, but definitely surgically accessible. And so I went over to Guy's to do this. But having learned from the previous case, I tried to make some things about the environment as normal as possible. So I took my own kit across with me. And I actually asked our vascular lab to come and do some TCD monitoring as well, so that I knew there was good cross flow and good MCA flow during clamping. And then I did a standard anti-jugular approach to the carotid, the same as I would do for any standard carotid endarterectomy. Which all looks a bit different when you've got some hematoma around it and a foreign body sitting in the way, but took my time, knew that there was good cerebral flow the whole time. And then once we were clamped up, I gave some heparin, clamped up, and could just put some straightforward sutures into the vein, which did in fact have a through and through injury, and into the anterior wall of the artery. And again, the post-op scan looked reasonable. Unfortunately, there wasn't any central venous stenosis as a result of the injury, and the patient was neurologically intact, so no stroke. And so what did I learn from that? Well, actually, in a position where you've got time, exactly as Todd was referring to earlier, the approach depends very much on the patient's status. This was a patient who was neurologically intact with no expanding hematoma. So we had plenty of time to think about what we were going to do and to come up with this decision that hopefully wasn't just okay to get us out of trouble on the day, but also gave longer term benefit for that patient. And I'm delighted to say he has now gone on and had a transplant further down the line. I also learned that even very familiar anatomy can look different in trauma. And so just taking your time and making sure that you're recognizing everything appropriately, I think is important in order to get the right repair. And I learned a bit about trying to make the environment feel as normal as possible. I didn't quite go as far as taking my playlist with me and my little Bluetooth speaker, but I took everything else that I could to make this feel like a standard carotid endarterectomy approach, so that I could perform at my best and within my comfort zone. So why have I picked these cases to talk about? Well, mainly because I think they highlight some of the cognitive skills involved in dealing with adverse events and trauma. And often in these iatrogenic injuries, they're very emotionally charged situations. And we all know ourselves from situations where you've been operating and things are not going well, that you've got a lot of emotional investment. And so coming in as a second surgeon to try and help in that situation, you can really come to the fore in terms of the way you communicate, in terms of the way you use the skills of the whole team, being able to think clearly and demonstrate some leadership in a situation that can sometimes feel chaotic, but also being able to recognize what you're seeing and also understand the impacts of that and what your worst case scenarios are, and try to work into your solutions a way to prevent your worst case scenario. Sometimes that can be a very analytical approach in the same way that we did with the carotid. Sometimes a bit more rule-based. I'd never operated on the route of the SMA in that way before, but I knew that I needed a tension-free anastomosis, and if I had a healthy artery, I could probably mobilize a bit and get that end-to-end. So a very rule-based scenario. But I think sometimes, and Rachel was alluding to this earlier, you do have to be slightly more relying on a bit of experience and being creative with your solutions, because you may be coming across something that you've never seen before. And so in summary, for those old schoolers like me who still do a bit of open surgery, this is the Hitchhiker's Guide to the Galaxy, which has "Don't Panic" written in friendly letters on the back of the first edition. So I think even when you're faced with something that seems very daunting, don't panic. If you employ the skills that you have and the whole team have very well, you can often turn what sounds daunting into quite a straightforward procedure. I would say look for unusual anatomy, because I suspect it often is part of the reason why iatrogenic injuries happen. Play to the strengths of the whole team and utilize the whole team in your solutions. Don't be afraid to phone a friend and use a lifeline, because they are invaluable, and we're lucky to work in a specialty where we work with some fantastic people who will always come and help. Normalize your environment as much as possible. And I think with hub and spoke networks, and when you're potentially going to rescue in different theatres or in different hospital environments, the more you can restore yourself to your own comfort zone, the more that you're going to perform at your best. And lastly, but most importantly, look after your colleagues. This happens to all of us, and the way that we look after each other impacts our ability to look after our patients, both in the immediate event, but also in future occasions where things go wrong. And I'm delighted to say that as a result of the first case, that urologist and I have become friends, and we both use that case for teaching. And he shared a fantastic video that I won't share the whole thing, but we both use that for teaching, because it has been a building experience for both of us, both learning about the cases and about the way that things can go wrong, but also about the way that we could look after each other and help that patient to the best of both of our ability. So that's all I was going to say.
Thank you, Bex. That was a fantastic talk. I was hoping someone was going to talk about the psychological sort of sides of being that person that has to go into a theatre where something bad is happening, and how you manage yourself, but also how you look after the people in the theatre. I think it's a fantastic technique to get them involved in the surgery. They often feel very responsible and are worried about the consequences of what's just happened, but getting them doing something that they are good at doing is a really good way of involving them and making them feel better. And actually, if it was me, it would be quite cathartic to be involved in the rescue, having caused a problem in the first place. I think those were really pertinent points. And I think the non-technical skills around managing that situation is something that is really valuable to learn, and the communication is absolutely vital. So talking and being, humble and recognizing that there's parts of this operation, I don't know, what side of the patient are you on? How am I looking at the aorta? Can you help me orientate?
Yeah, absolutely. Talk me through, what am I looking at? I totally agree. And And actually, again, I think that's an empowering thing for the team who are operating and are in the midst of this absolute disaster, that just being able to go back to first principles and realize not everybody else can do what they can do. And so they can explain to you where they're at and what's happened and how they've got there. I think that's a helpful debrief process for the team involved as well.
What's also nice is that I had to ask the urologist that you went to help to come and help me when I got myself into trouble. So it's a two-way street.
Sure.
So yeah, no, often the people you have to help will need to come and help you as well. Excellent. Any questions from the faculty? There don't seem to be many questions on the
there's somebody asking what incision the urologist used. No, the patient was already in a lateral position, so they did a retroperitoneal exposure flank incision, which was great because it just is the same sort of approach as a thoracoabdominal incision, and got me just onto that, right? But and then they've taken the whole kidney out of the way, right? So there's just this enormous gap where there was a kidney that I can see exactly what I'm doing, and it becomes very easy. So that was great.
Yeah, no, really fantastic talks all this afternoon. I think so. We are running a little bit behind time, so I may move on to the fourth poll, if that's all right, Jeanette. So this is our fourth question, which is a statement regarding anatomic classification of iatrogenic vascular injuries is true. The clinical presentation, diagnostic assessment and management of iatrogenic vascular injuries vary depending on an anatomical location. That's the first one. The clinical presentation, diagnostic assessment and management of iatrogenic injuries in the extremities is the same as those in a junctional region. The third, the junctional vascular region is that between the thoracic and the abdominal aorta within the torso. Iatrogenic vascular injuries in the extremities are particularly difficult to expose and thus should be treated only with catheter-based endovascular methods. Sorry, I shouldn't laugh. Well, it's pretty unanimous. At the moment, only 48 of you have voted. Numbers going up. I doubt that this is going to change, but I would agree with the answer is A. A few sporadic people have gone for other things, but yes, definitely. It varies dependent on anatomic location. You wouldn't do the same thing in the neck that you might do somewhere else, for example. Excellent. So, last but not least, definitely. So our final speaker today is Michael Park from Cleveland Clinic in Abu Dhabi. I'm very grateful that he's come in from the sunshine and recovered from COVID enough to be able to give us some vascular complications of ECMO. Michael, over to you.
Thank you very much for this opportunity to speak. I've been actually obsessed with this particular topic because it keeps coming up. I just recertified in ACLS, and the PEA and asystole algorithms really haven't changed, but it seems like we've devolved to adding ECMO at the end of this. So we see more frequently here, at least in the UAE, patients showing up with ECMO. And some of these are rescued actually, but it's becoming also more prevalent because of COVID, especially VV ECMO. And so I thought that it'd be timely to review this. These emergency ECMOs are placed oftentimes without ultrasound guidance. They're placed with a needle and Seldinger technique and placement of large sheets into artery and vein, and then all the possible things that could happen do happen. The case that I'm going to present briefly is one that happened last year, where I was called into a cardiac OR. At the end of the case, they had placed a venous cannula after a mitral valve replacement. They were going on ECMO, and the patient developed a rock hard expanding abdomen, and they weren't able to come off of bypass and a whole bunch of other things. And it was clear to me that that there was probably a venous injury. The sequence of steps involves placing a wire into the vein, much like you would for a central venous line. And when it's done in a control setting of an operating room, there's usually a TEE, so the anesthesiologist will look for a wire to come up into the SVC and say, hey, we got wire, and then they'll pass the device. The thing that happens is that, one, the wire they use is very flimsy. It's a steel core wire that doesn't really support well. Has a J-tip, so it doesn't really steer and guide well. So the best spots to place these are always the right IJ, the right femoral, and that's why I tell them just go for the right. There's anatomic variation on the left side. We all know this. The coronary sinus, the persistent left SVC, retroaortic left renal veins. All these can cause problems because you'll see a wire in the SVC, but the wire may be not taking a great path. And I conjecture that this patient probably had this situation where there was probably some May-Thurner type compression, and pushing the cannula forward resulted in this sort of injury. I was called in. We looked at the patient. The patient was not doing well, and so they had already called the radiologist and did a venogram, and the venogram showed no extravasation, which is common with these venous injuries, is that they'll tamponade themselves, and this patient was really suffering from what was an abdominal compartment syndrome. So did a decompressive laparotomy on him. These ECMOs cause problems in many different ways. The most common scenario that has happened this past quarter has been accidental decannulation. When that happens, the patient is essentially bleeding to death. And you got a big hole in the artery. And again, walking through this trauma issue, it's very straightforward to make an incision above the groin into the external fascia, and stick your hand in, and you feel the psoas muscle. You see the artery, feel the artery, and you just clamp the artery with your finger. That's a very important maneuver, I think, that people have to get their heads around, and it's very easy to learn through doing spinal exposures, elective spinal exposures, and working with their urologists and general surgeons. But it is possible to get your hand in blindly all the way to the aortic bifurcation, all the way up to the thoracic aorta, even with your hand just marching up the retroperitoneum. And so that's a very important maneuver to know. And so I was able to get my hand around the external iliac artery and just clamp it with my fingers until we got the patient to the OR and we were able to repair. That can be life-saving. The venous injuries like this, I didn't manage because the patient had really just needed decompressive laparotomy, but the venous injuries I've developed this tool. It's basically the ring of any clamp. Any surgical instrument has a ring where your finger goes through. You can press down and create a hemostatic field that's much more visible and operatable than you can with sponge on sticks. Typically, you're taught put sponge on sticks and hold and look until you find the hole in the vein. I was able to make these. In fact, if you have a metal worker or a hospital a tool facility, they can bend rings like this for you, and they're very useful. Our thoracic surgeons use these for VATs, controlling pulmonary vessels. If there's bleeding, they can just tamp down and bleed, and we've used it in laparoscopy. So this is a nice little bit. The arterial access complications of ECMO are errant puncture, arterial dissection, and then wires going into places they should not, and then assuming that they're in a good place, they pushing the sheath through. And so these have to be sorted out early. These patients are on ECMO because they're dying, And any complications that happen up front have to be sorted out when they happen. And then the unintended decannulation is the final one. Then there's a whole panoply of early complications. So these patients who get emergency ECMOs oftentimes sit on a medical ICU service, and everyone's happy that they're alive. There's oxygenating, they're saturating, their hemodynamics are fine. They miss the fact that there's actually ongoing ischemia and swelling. So in fact, the delivery of blood flow and renormalization of flow can cause ischemia reperfusion in that limb, which now is handicapped by the presence of a large sheath. And then the distal perfusion cannulas are often assumed to be great, but these are people, these are cardiologists often who aren't always tied into putting in peripheral lines into, for example, the mid SFA or SFA below the common femoral, and they'll do it oftentimes even without ultrasound guidance. They'll just sort of poke until they get blood back, and they'll try to get a wire in. So these patients develop ischemic complications, and then any ECMO cannula malposition that may work fine for the first few hours quickly goes sour. It becomes manifest within the 6 to 12 hour period afterwards. Oftentimes that's too late. You've lost the window on saving dead muscle, dead nerves. And so again, these have to be assessed very hard and early on, especially after an emergency ECMO cannulation. The assessment of the ischemic leg in ECMO is a challenge because, again, we're used to having pulsatile flow. When they're on ECMO, they're essentially in DC. And so instead of alternating current, you're now in DC. You just have flow, and you may or may not hear a signal. You may hear something like shh. I don't know if you hear it. That's a great signal, but that may signify the patient's getting enough blood flow. You really don't know. One of the ways we've tried to objectify this is placing these tissue oximeters, the calf oximeters they use in the ORs, and compare calf to calf, the unaffected calf or unaffected limb to the ECMO leg. And that a large differential, particularly over 10, signifies there may be some ischemia going on. And it's also critical to understand the time of this. And so again, these patients may show up and you may be consulted the next day, 12 hours after the fact, that you're saying, oh, this patient's been stable, they're doing great, the foot's a little cool, do you mind taking a look? At that point, all the muscles are dead. they've had ischemia, and it's too late. But you do have to walk through this evaluation very carefully. Total CKs are a late sign. They're not helpful up front. Temperature and color are, again, very variable. It can be completely white and blanched because of the medications they're on. It can be purple and warm because they're venous congested. They have venous congestion because of a hematoma, but aside from that, you're not getting much blood flow. The distal perfusion cannula is traditionally placed in the SFA antegrade position. We've discovered that it's actually possible to perfuse particularly in the normal people who need ECMOs, tibial access. And we're all good at retrograde tibial access. And so placing a 5 French micropuncture sheath into an anterior dorsalis pedis gives you enough flow to preserve a leg, and it's very simple. And the intensivists can be taught this. It's an arterial line for them, it saves the enigma of that. Oh, where is the tip of our sheath, our 6 French sheath in the SFA? This was actually looked at in a paper that came out a couple of years ago. The absence of distal perfusion cannula predicts limb loss. There was a 21% ischemic complication rate in the absence of distal perfusion cannula, and there's still a 3% rate with a distal perfusion cannula. And so this is from Germany, and again, it's our hospital practice here as well to insist on distal perfusion cannulas early, whether or not you feel like they're needed, because these patients will sit 10, 12 hours with ischemia without perfusion, and then they've lost their leg. The retrograde perfusion is now, we've gotten into like 20 patients we've done successfully, and it works quite well. The one thing I have to say though is that these patients again do develop compartment syndrome from either passive edema, swelling, or from ischemia reperfusion, and so they do need, some of these patients do need fasciotomies. So again, the late complications of ECMO are these dead legs, peripheral neurologic complications. These patients, again, even if they're well perfused, will have neuropraxia and dead peripheral muscles that don't work. Foot drops are very common. And then depending on how long they're on ECMO, we've had patients several weeks on ECMO, they develop infections, arterial infections, particularly that require reconstruction, and the wound complications that come from having an open groin. The other complications of ECMO are the decannulation operation. So in fact, we've gotten with the what we call medical ECMOs, the vascular surgery has been directly involved in decannulating the medical ECMOs that don't involve cardiac surgery, and it's a profoundly complicated procedure that requires a lot of coordination with cardiology, cardiac anesthesia, and it may or may not go off because the patient may not be able to survive off ECMO. Thank you very much for this the opportunity to give this disjointed talk, but I think it's a very important topic.
Thank you, Michael. Great presentation.
Yeah,
I'm
nice.
always very wary about ECMO. I think there's all sorts of complications related to the cannulation and the pipes and all sorts of things. I've seen some terrible things happen. It can't be underestimated, I think. So there's some questions coming in from other people's talks. Anybody on the faculty got some questions for Michael?
Yeah, Mike, have you seen, I mean, ECMO's obviously been around for a while, I think, but not, but it's still a relatively recent thing, and it's being adopted in more and more units. I think COVID has probably pushed that on. Are you seeing ECMO patients, more sort of sicker ECMO patients, or it being used in more and more extreme circumstances than you have done previously?
Yeah, they're really pushing the envelope because we're a cardiac referral center. What typically happens is the patients are stabilized and then transferred over, and so typically they end up coding, having some combination of a PEA asystole. They're put on ECMO, they're brought over, and those patients don't do really well, but occasionally we get a survivor. The prevalence of COVID has brought up a lot of the BV ECMO for the lungs, and those patients do great. It's life-saving, I think. But the AV ECMO, again, I think we're all, everyone's learning what is possible and what shouldn't be possible, and so it's.
Can I just? That's great, Mike. Thank you. There's we've had a couple of questions that have come up about. I don't do spinal access stuff myself routinely, so I don't know if any of the panelists do. There's been a couple of questions about particularly spinal complications from dealing with spinal veins, spinal venous bleeding, or bleeding sort of deep in the pelvis. I don't know if anyone wants to tackle that one.
spinal venous bleeding. So the trick to spinal venous bleeding is to not get any. So it's your exposure going in, making sure that you divide, double ligate, I don't care what your technique is, of all the big iliolumbar veins that cause you problems if they just disappear. And taking great respect of the iliac veins, depending on what level and where you're moving them in relation to the spine, and making sure that you've got enough laxity so that you don't rip them. I think the most dangerous cases I've done are the ones that are done for cancer, where the tumor planes are really destroyed by the cancer process, and you can't tell what's vein and what's cancer. But for your standard spinal exposure, if you do the dissection well and you take the tributaries and you mobilize the vein adequately and you use the retractors that the spinal surgeons use, you should be all right. I mean, obviously, if you get bleeding down a deep, dark hole, then, you know, all the techniques that you would normally use to control venous bleeding and get it sorted out. So phone a friend, push on it, top and bottom, know how to stitch down a deep, dark hole. I don't care what your techniques are, they all come into play, but actually the best technique is perfect access exposure, ligating the veins as you go so that you don't get into trouble in the first place. Brilliant.
Okay, I think we are almost 15 minutes over time, so that I think probably, given that I know there are more questions coming in, but we could sit here all afternoon and talk about it, but I think my family might have other things to say about that. There is a quick question about imaging in ECMO patients. Mike, do you want to just answer that quickly?
Sure.
Is there a role for imaging for assessing patients on ECMO?
I think that there is probably patients who have tough access. So these are patients being placed on ECMO, let's say, during the course of a cardiac procedure. And I've been asked to come in and help out with getting wires up and across and through. And in general, I haven't had to bring in a C-arm, but it's always available. So these our cardiac tables will tolerate having a C-arm placed. It's not ideal. So being facile with C-arm angiography, the old-fashioned way, squirting and watching on screen, is a good skill to have always. In this case, again, it's the wire. It's giving them a stiff glide wire. Solves the problem. It's typically the wires that come with those ECMO kits are horrible. They're 270 length floppy steel core woven wires, and it's impossible to steer them properly.
Brilliant. Okay. All right. I think that probably is. We've been going nearly 2 hours now. I think that's excellent. And I'd just like to thank all of our speakers for giving up their time at different times of the day around the world. It's hugely appreciated by BSET. And you know, the talks were fantastic, and I've learned a lot sitting here. So thank you very much. I'd like to remind everyone about the BSET national meeting, which is taking place on this coming week on Thursday. So please do register for that. There are, again, excellent speakers there. And finally, you will get an email if you've registered. So please do give us, asking for feedback. Please do give us feedback. This is our final webinar in a series, and certainly, you know, this is probably, there'll be an element of this going forward in the future, and the more we can learn about how to make these better, and that comes from good feedback. So thank you very much, and I shall draw this webinar to a close. Thank you very much again to all our speakers.
Thank you very much.
Thank you.
All right.
Todd, Peter, Michael, Becky, fantastic.